Death has important legal, medical and societal implications, and one of the duties of a doctor is to confirm death accurately, reliably and with certainty. It is important then that clinical staff have clear and easily applicable guidance on how to recognise when death has occurred. In the UK, this guidance comes from the Academy of the Medical Royal Colleges and was published in 2008 in a document called A Code of Practice for the Diagnosis and Confirmation of Death. This audiovisual guide is based upon this document. There is broad consensus, particularly in the Western world, that human death is ultimately related to irreversible loss of brain function. In the UK, the Academy of the Medical Royal Colleges has defined death as the irreversible loss of the capacity for consciousness combined with the irreversible loss of the capacity to breathe. Of course, this is a state that can be arrived at in various ways, and this means that different criteria will be required depending upon the precise clinical circumstances. Most commonly, death is diagnosed after permanent cessation of cardiorespiratory function, and in these circumstances, circulatory criteria will apply. On other occasions, so-called somatic criteria will be more applicable, for example, following massive trauma or when a body is laid undiscovered for some time. As a result, these criteria are most commonly used by ambulance staff and are sometimes referred to as criteria for the recognition of life extinct. However, there are occasions when a patient may satisfy our overarching definition of death, that is, irreversible loss of the capacity for consciousness and irreversible loss of the capacity to breathe, after a more direct injury to the brain. Of course, without medical intervention, one element of this, central apnea, would result in hypoxic cardiac arrest, and much the same end result as for death that follows a primary cardiac event. However, if the patient has been intubated and ventilated before this terminal event, we find ourselves with a patient who is deeply unconscious and apneic, who apparently fulfills our criteria for the diagnosis of death, but whose circulation persists for as long as they remain on a mechanical ventilator. This is when so-called neurological criteria may apply, and this is what this training video will cover. Before we move on to consider in detail how we make the diagnosis of death using neurological criteria, it is important we recognise that this is a diagnosis that has been made in the UK for over 40 years. However, for much of this time we spoke about brainstem death, and whilst this was useful, in as much as it emphasised that complete loss of brainstem function will result in deep coma and apnea, it was misleading because it gave the impression that there are different sorts of death and that the differences between them are essentially anatomical. We have moved on from this view. There is only one death, the irreversible loss of consciousness and respiration. What varies is how a patient reaches this state and which criteria best suit the circumstances. For these reasons, we have tried to avoid talking about diagnosing brainstem death and instead will refer to making a diagnosis of death using neurological criteria. It is also important to understand that this is not a diagnosis that is made very often. Indeed, it only accounts for around 5% of deaths in UK intensive care units. And we know that clinicians can sometimes feel nervous about making the diagnosis. Standardised pro forma and operational policies can help in such circumstances, and both the Faculty of Intensive Care Medicine and the Intensive Care Society encourage clinicians to use forms such as this that are available to download from their websites. We also encourage their use. We will start with a few simple rules around who can make the diagnosis and how they should go about it.
So Dale, this is a gentleman in his mid-50s who was admitted some 36 hours ago with a sudden loss of consciousness after...
Firstly, the various assessments and examinations that together represent the means by which death is diagnosed using neurological criteria must be carried out by two doctors. Furthermore, the two doctors must work together rather than separately. Next, both doctors must be registered with the General Medical Council and have at least 5 years' experience post-registration with the GMC or an equivalent overseas body. As a minimum, one of the doctors must be a consultant, normally the intensive care consultant who is caring for the patient. Finally, both doctors must be trained to make the diagnosis and be working in a specialty appropriate to the task. They must not be members of a transplantation team, nor have any involvement in the subsequent implantation of organs or tissue that are retrieved from the patient after their death. There are two mandatory stages to making a diagnosis of death by neurological criteria, and the two doctors making the diagnosis should work together during both stages. In the first stage, doctors must be assured that a patient meets certain preconditions to ensure that their condition is not treatable or reversible. The second stage involves examining the patient and performing various tests of brainstem function. It is important to understand that whilst the clinical examinations in stage 2 demonstrate the absence of function, its irreversibility is dependent upon the detailed and careful assessments in stage 1 that allow the preconditions to be satisfied. The rare errors in diagnosis that have occurred around the world are invariably made during this initial step. Occasionally, clinicians will decide they need to supplement stages 1 and 2 with an ancillary or confirmatory examination. Whilst there is no mandatory requirement in the UK to carry out such an examination, there may be occasions where they help, and indications for their use is covered elsewhere in this toolkit.